Here we are. Welcome to London, guys. Welcome to London.
Thanks a lot. Well, good morning, everybody. Thanks, Lorenzo, for the kind invitation. Let's see how this is going. I think first the music was wrong because it should be the first cut is the deepest, you know, because we're talking about directional atherectomy and cutting a lot.
Kiss you on, yeah?
So, but anyway, that's fine, of course. These are my disclosures, but my main disclosure is I really don't know what my mission here is, although you're looking forward to this presentation. It was actually a coffee break with Lorenzo at PVI, and then he said, you know what? Talk a bit about your techniques of atherectomy, show some of your research and send me a title. And so this is all like the real, this is my message, this is my mission. And the thing why it's a bit about my research is because I do have various research focus, and of course very much I'm related to clinical trials, and this will be always at the heart of my research. But also since 2-3 years, I'm actually heading a translational research institute, and some of the stuff I'm going to show you is data which we have retrieved there. But of course, it's not just this one, because that will be very boring Sunday morning, but you're also going to see some cases. Again and again, we have multiple options for lesion preparation, angioplasty, various balloons. Of course, IVL, I mean, is the really relevant kit on the block right now, and atherectomy, which we are using for many years. But the thing is, we do lesion preparation in various lesion pathologies. And this is something I actually like about my research. I do not have access to IVUS a lot because it's really reimbursement is a big issue and I can't show you these fancy pictures. But I do have access that I actually can do quite some histology of the patients I treat. So I'm going to show you some histology samples of atherectomy we did. And this is actually from a patient we sent to amputation. We also do have some patients. We discussed yesterday how many. Most patients we send over the winter season. It's mostly about 4 to 5 patients, I would say so, per year. Maybe a little more sometimes, but not so many. But we have discussed yesterday about IVUS assessment and how you choose your balloon size. And what I would like to highlight is, so this is an occluded posterior tibial artery of a patient we sent to amputation. This is actually your lamina elastica externa, and this here. So this is the size of the balloon you will choose based on IVUS to open up this fully occluded vessel. And I mean, I think it's massive what we are doing here. And when you look at these pictures, you're actually super impressed that we do not see more ruptures, especially with the large balloons. The other side is, we do have fibrocalcific plaques in mostly all interventions we do in peripheral arterial disease. And this is something I'm going to show you several times. These are these dark black dots. This is a Fancosa staining where you actually stain calcification. And also you think this is a quite fibrotic plaque. There's always, almost always, apart from instant restenosis where we really have pure neointima, you almost always see calcification. And then we have talked about medial arterial calcification and maybe why drug-eluting balloons do not work there. And this is the histology of a patient with severe medial arterial calcification. Actually, in the histology, the plaque is completely destroyed because the calcification is breaking out. So this is here actually all calcification in here. It's in the Fancosa staining, you still see the calcium attached to the walls, but there's hardly anything left over from what we would call intima or media or so on. And so, of course, I mean, how should a drug-coated balloon work in these lesions? So these are the challenges for atherectomy, calcification in all these various forms, long chronic occlusions, of course, and small vessel sizes in particular, I think. Well, these are the high-end vessel-prepped devices. These are the one I have available in clinical routine. I'm not going to focus all of them. I think that is really not the purpose of this session. To be honest, I know August said yesterday, Rotarex is no atherectomy device. I worked also quite some time back in the years when we were still in the Park Krankenhaus, and we used Rotarex like crazy, I would say. So you can use Rotarex also for fibrocalcific plaques, but it's a bit difficult. But I still would, there are situations where it's really useful to go for that as well. And I'm showing you this because the next slides have to do a little bit with our Rotarex background, I would say. So the advantages of atherectomy, of course, I mean, this is pretty obvious. It removes atherosclerotic and calcific tissue, and we all expect some lumen gain. And this is also related to the question before, after the IVL of the iliacs, there was no add-on therapy. And is this actually what lesion preparation is? It's the preparation for the next therapy step you're going to do. I do think the methods in various degrees do give you some lumen gain, of course. I personally, the more I do it, I think it's really about changing vessel compliance and preparation for the next therapy, which is facilitating balloon angioplasty. It definitely decreases the chance for dissection, avoiding additional stent placement. I mean, this idea of simultaneously like kind of optimize the drug delivery. I think this is more an idea we have, to be honest. It really depends on the plaque you're treating. If it's not super calcified, I think the paclitaxel will find its way somewhere. It's very fast tissue absorption. If you have these super calcified plaques, I mean, whatever you do, there is no tissue left over for resorption.
I mean, we already have the data of how much drugs from the balloon passes to the vessel. And it's already, the percentage is extremely low. So if you add calcium, probably then it is really difficult to reach and to have a substantial benefit for the patient. You know?
Especially, I think with the lesion preparation, you can't get rid of all this calcium which is there. So it's, of course, it helps. I definitely think so. But I mean, we are all aware. So far, we never really achieved to show improved patency by lesion preparation. And it's not just our issue. Even the cardiologists, they were not able to show that. I mean, the story there is a bit different because it's really lesion preparation for stenting, so it's more difficult. I think they will end the 2,000 patient trial this year, adding lesion preparation before stenting and not. Let's see if they win here with respect to that. With respect to these very heterogeneous plaques we treat, I don't believe it will be easy to show that will really improve patency. But anyway, so the goals really are to avoid stents. I'm not so sure if there are any no-stent zones are left over. I don't really think so, apart from the distal tibial arteries. Yes, these are no-stent zones. But apart from that, it's more about, for me at least, about bifurcational disease. I don't like bifurcational stenting. Actually, the background from atherectomy devices was really to tackle uncrossable and undilatable lesions. Of course, debulking, especially in coral reef situations, can be very helpful. And it's also for optimal stent expansion, because I think that is something we maybe are not so, let's say, so focusing that much as cardiologists do. And I think this is something what we really can learn, that it's also important in our field to have optimal stent expansion.
Because I think many times we feel that if we use any atherectomy or any vessel prep, the stent is, we're losing. Probably we should also rethink this.
I totally agree with that. I think this is what we know from the data. This residual stenosis below 30% really plays a role. And we know from the data that we as operators are not judging that well. So because when you bring the data to the core lab, the rates of residual stenosis are much higher than the operator adjudication. And I think this is really important to keep that in mind. It's important to have a very good stent deployment. In-stent restenosis, of course, is a big issue. But it comes with extra time, extra costs, and of course extra risks. So just focusing shortly on calcification, we talk about that all the time. I mean, this is severely calcified according to our classification systems. Of course, it's not. Something like that on the next picture is severely calcified. I think this is what is an issue for us in clinical routine. And it gets even more complicated below the knee because we see so many phases there. I mean, we talk a lot about medial arterial calcification. Yes, we do see these patients, but in many of these patients, it's really combined with eccentric calcification at certain spots, which are then so hard to tackle. This would be more medial, but even here you see some areas where there's definitely also intimal calcification. So I think it's a combination in most cases. And this is then the rocks, which, well, are really making life very difficult. So I'm talking a bit about jet stream. It can address multiple types of morphologies, fibrotic and calcified. That's the indication I would use it most. It has disadvantage of rodent cutting, active aspiration, and this is going to be a little bit the one issue of my talk. And of course, you also can achieve a larger concentric lumen by using expandable blades for the bigger sizes devices, which you use typically in femopopliteal interventions. So the XC devices with the expandable plates. So that's a typical lesion where I think jet stream is really helpful. You have these heavily calcified regions, which definitely would necessitate stent implantation if you do not do a lesion preparation with an atherectomy device. The problem really is, and this is a little bit when you come from a cath lab where you have rotarexed so much, go as slow as you can. You hear that in the presentations and of course from the companies, but what it actually means in real life is a different story. And for us, filter protection is quite crucial. So this is like yesterday, I think August showed some pictures where he was really quick, and you mentioned that this is definitely not the speed you should go for.
Yeah, it's like usually, you always do these videos with like multiple speed, like.
Exactly. So I thought I'd do a video with not multiple speed so that everybody gets really, really bored. It's important to do so, but still you do have embolization. And this is a distal filter with debris, but you see here you have an embolization in the genicular artery. Interestingly, when we look at the data, in-stent restenosis seem to have the highest embolization risk. So there's maybe something about this fibrotic material. You just keep that in mind. And this is what I wanted to show you, because these are some filters from Leipzig in the very beginning when you come from a Rotarex lab moving to jet stream. This is what happens. Axel Fischer is a super experienced guy. He's doing now our advanced aortic program. But when you go too fast in heavily calcified lesions, you just have this massive embolization. So going as slow as you can, but still I believe the Japanese are really good. They have jet stream now available for, I think, a few years. They do not have distal filter embolization, and I believe their data, despite being really patient and skilled interventionists, and I think the Japanese are that, they have a 10% embolization rate. So it's really, when we talk about atherectomy, and it's all great, I mean, it really depends, especially when you can't protect all the below-the-knee arteries, when you have a poor runoff. It's really the question, would you take the risk for yourself of a 10% embolization rate, or maybe go for a supera stent in the femopopliteal segment, where we also do know with a very good preparation, we can have very good results. Or as you do another approach, and this is a case of a left distal SFA, very calcified lesions. Patients.
Yeah, there's a question.
Can I just a very short question? The 10% embolization rate with filter?
No, without filter.
Okay.
So this is this in Japan. They do not have filters available, but they really do a great workup of their data, and I really believe that they are going slow and patient and so on. So this is 10% what's there, but even with filter, the thing is you have embolization in the proximal parts. It can go into collaterals. Or like in this case, where you actually have a poor runoff with a 2-vessel outflow, you don't really want to lose any of these vessels. So this is really an issue about atherectomy, I think. This is a concept André has developed a few years ago and we follow now quite a lot. So if we want to protect both arteries, or let's say a dual outflow, a dual distal protection, bringing in a retrograde sheath is in most of these cases not that challenging, especially here of the puncture of the high tibial anterior artery, where you also see a nice calcification. You can bring in the filter into the perineal. You can make a pull-through wire through the forefront sheath for embolic protection. And this then actually allows you to do a balloon protection from distally with a filter protection. And then you really reduce this risk, this residual risk, I would say.
I love that the wire moves when the gestream advances, like it's shaking like dancing, you know what I mean?
Well, that's your imagination, isn't it? So a very good result here. But now I'm moving forward, and this is a little bit a different topic. It's a directional atherectomy. I think we all know what it is, and I love these pictures or the images by the companies, because the block is so homogeneous. You know, it's all like an easy world. Everything is easy. It
looks like almost parmesan, you know.
Yeah, reality is very, very different. This is reality. This is a patient I treated a few weeks ago. Very young patient. I wanted to avoid stent implantation. I did directional atherectomy, and this is actually what you get there. Hardly any calcification, although if you look very closely, this was a patient not even 60 years old. Already here it starts. It was in the adductus channel, so the typical location.
So the red, it's calcium?
Sorry?
What's calcium red?
No, the calcium is black, and if you really look closely here in this staining, you have the black spots in there. So it's the calcification starting in the media, and this is what we see a few years later then, that in the adductus channel you have most of the calcification going on. It just starts, it's part of the process. We don't have these lipid-rich plaques as we have in the carotid arteries and so on. That's not what you see in the peripheral arteries of the limbs. But this is one picture. The other thing is something like that. You only have fragments here. And the reason, again, is all the calcification that has been broken out of this vessel segment. And even if you look closely, it's just this black here. It's calcification all over the place. So this is what we actually get. And it's not that nice a picture as we saw in this little film. But where would I use it, and what is really for me an important indication? It's really these SFA flush occlusions. At the end of the day, if it's a real flush occlusion, most of the time you have to bring up the stent just a little bit in the common femoral. And although there are some data out there that the jailed profunda doesn't matter, I think most of us don't feel comfortable with these profunda arteries or deep femoral arteries affected by stenting. And of course, there can be, this is also what we saw yesterday in the Rotarex case. Typically, you have this edge stenosis when you have in-stent restenosis. And when you bring up the stent very high, really to the bifurcation, you have your edge stenosis there. And it's very difficult to treat this edge stenosis and to get rid of the fibrotic material here. And this sometimes ends then in stent. And, well, it's all not very good for the profunda, which I think is crucial for the long-term outcomes of these patients. So that really can provoke stenosis in the deep femoral arteries. So here I think as a directional atherectomy is fantastic. You can kind of open up this proximal SFA. Thomas Seller now, because they don't like to do all the distance of these long occlusions, they do directional atherectomy of the proximal and distal part, because this is the zone where you typically have the dissections and you need to stent when you open up these vessels. And you can treat that nicely again, adding DCB treatment to these procedures. Also here, calcified lesions, I think, are the one that are embolizing most. When you look at the histograms, it's really logical. The calcium is just breaking out. When you're touching these blocks, it's clear that the calcium will start breaking out. It's something you can't avoid, I think. So, of course, distal protection is necessary. In these cases, I would go for the superficial femoral for my filter positioning. And most time doing the deep femoral without protection than in a second step and just hoping not too much embolization.
Just a second, August, based on your experience, do you think that here also, because you published this stuff in the BTK, again, also Sabine, can you puncture the SFA retrograde, put the balloon, put the filter in the FA, and then try to, to aspirate whatever is on the balloon if it's an SFA? What do you think, August?
I think so. We basically do it that way.
Definitely you can do it. I mean, it just, at the end of the day, it always adds some extra time, and this, of course, is an issue. But that's a very good option, definitely. I think this retrograde protection is absolutely essential when you go for a lot of atherectomy, especially.
Because the SFA looks pretty healthy, so to puncture a vessel, what do you think, guys? What would you do in this case? Kuhn, Theo, Gregorios?
I wouldn't protect the deep femoral. I would go directly for the SFA. And in the majority of the cases, it depends on which direction you're cutting. So if the plaque was at the level of the deep femoral artery, yes, it makes sense. But if it is on the side of the superficial femoral artery, I have not seen any big embolizations. In the distal branches, maybe, but we're not looking so distally to embolize for embolization.
Kuhn?
I would protect the SFA, and although I'm a vascular surgeon and people are always mentioning the deep femoral artery is the holy artery, can be, but it's full with branches. And so if there is some distal embolization, I'm always able to push it in one or another collateral side branch, whatever, and so that the loss is really restricted to a minimal.
Gregorios?
I think it depends on the atherectomy system you're using, probably, the risk of embolization. So with a directional device, I would probably use a filter, probably rather in the SFA.
Can I just ask you, Sabine, so are you aiming for a systematic use of a filter even in rotational atherectomy? In any case?
I mean, it always depends on your local situation. So as we have pretty free, we don't have IVUS access, but free access to filters. Yes, I would do so. I mean, of course, it below the knee, it doesn't work. We don't have the small filters there. But of course, there you can bring in a sheath for distal protection by really opening. This is what we do with CSI, for example. So bringing in, especially in single vessel runoff, where you really want to protect this vessel, bringing in a retrograde sheath, 4 French sheaths from below, doing the CSI, and while you do the procedure, open up the sheath and kind of almost aspirate blood out there to really retrieve all debris. For the proximal part where you can use a filter, yes, I would go for.
Okay. And the second one, an atherectomy followed by drugs always, or?
Yes.
Sabine, just a short question. Can you go back? Because for me, the biggest problem with the common femoral artery is that this vessel has a big diameter, and sometimes the hook one does not touch anymore the plaque.
Absolutely. I mean, in a way, you have to touch the plaque. That's right. This comes a little back to what I've said in the very beginning. The question is, how much do we need lumen gain and how much do we need vessel compliance change? And I think you also can achieve quite a lot if you're able to do some directional atherectomy there in changing the vessel compliance and having a good result with additional angioplasty. And of course, sometimes we need stents, and we all know it's not a big issue to use a stent in the common femoral.
We will see also with Kuhn later with the common femoral artery talk. We're going to come back to that.
Okay, now let's go a little bit back to what Lorenzo actually wanted, some research. Does it matter which material we retrieve? And this is an old publication which I still find extremely fascinating. 116 patients, they looked after directional atherectomy, how deep was the cut? And this is why I think the first cut is the deepest, which I don't think is the issue here, would have been the ideal song. So they looked at 116 patients. In about half of them, they had adventitial injury. And this is also what I see in my specimens I retrieve. It's really not that easy to avoid adventitial injury. They had a 1-year restenosis rate of 57%. This is pre-DCB. When you think of the Viva Reality study, they had a 1-year restenosis rate of 77%. So these are the 20% freedom from restenosis, sorry for that. this is this add-on we get from DCB treatment, of course. But what was amazing, almost all patients who had adventitial and medial injury, they showed restenosis. So the idea was there, if you go too deep, you have a deep vessel injury. A deep vessel injury means a more intense healing process, more restenosis. Now we have the idea that this is gone because we use DCBs, but to be honest, we really don't know if it still matters or not. So Thomas Seller saved his directional atherectomy specimens for a decade or so in liquid nitrogen, and he opened up his treasure box for us. And so we do some histological analysis of these samples. Again, just one sample I love. Again, this is the external lamina externa here. This is a very thick media, and you do have some intima, not a lot. But what is fascinating, again, you see the calcification starting at this border zone of adventitia and media and just growing into the vessel. And so we look if the adventitial injury is associated with restenosis there, but we, in a way, we kind of are a little bit more modern nowadays. And this has to do with this research institute I'm heading right now. I'm working now with really smart people. I always think they are much smarter than I am. They do really a lot of translational research. So we started to do untargeted proteomics on these samples by doing mass spectrometry and by comparing then the proteomic profile of these various specimens. I mean, we are still waiting for some clinical data. We have analyzed now around 130 plaque materials. We do have instant restenotic material. I mean, it's that old, the material we have. We don't do directional atherectomy nowadays of instant restenosis, but it was done about 10, 15 years ago, and we still have samples from that. And just to look at the protein expression profiles, and if you can relate that then also to the clinical follow-up of the patients will be interesting.
Kun wants to ask a question.
Yes, Sabine, very interesting, this basic science. Do you also make a sub-analysis in terms of which atherectomy device you use?
No, this is all directional atherectomy.
Should it be interesting to see if there is a difference of retrieving material with different atherectomy devices?
This is a different project I'm trying to kind of get started. The cardiologists have actually published that when you collect the balloons, you do angioplasty, you can do proteomic analysis on these balloons, and this is what we are going to transfer to the peripherals, because this kind of will give us an insight. We talk a lot about stuff like halo phenomenon and so on. What are actually the proteins that are behind, let's say, these lesions we observe? So we go on with this depth of vessel injury. Does it matter? What about the healing process? And I think what we know for quite some years now, if you go too deep, you can see these ectatic changes. And also, for example, Thomas Seller says, if I have cut into the adventitia, I don't want to use a drug-coated balloon anymore, because he thinks that there's more ectatic changes, like in this patient with an aneurysmatic change of the vessel. So it's really the question, does it matter where we transfer the paclitaxel? I don't think we know. I mean, it's really fascinating that we can look now with IVUS actually into the depth of dissections, and it would be nice to combine this data then also with restenosis, rates of restenosis, if it actually matters what we do then with our balloon angioplasty. But I think what I would like to highlight, I don't know how it's for you, but I see from time to time on a quite a regular basis ectatic aneurysmatic changes after aggressive vessel prep and DCB treatment. And this is not just directional atherectomy. This is just aggressive vessel prep. And it seems that some patients are more prone to that, especially young patients, no calcification, subintimal via passage. So I don't know if it's a concern for others. I think it's a certain pattern of healing that some patients do show, and we don't really understand in the beginning if this will happen or not. But I'm happy for any comments on that, how you see that.
I don't know. Panel.
So, we see it very frequently after atherectomy devices. Here, a remark.
We have done in Germany a comparison or a histological analysis between lesions that have been treated with the Pantheris system, which is an OCT guided where you probably know that you are not reaching adventitia, and the HOC1, and at the end we have not seen any difference. So that means even if you are looking with the OCT where you're cutting, you're not avoiding to cut adventitia. So this is my remark on this. And we have seen this halo phenomenon with the Eluvia stent, which is, I don't believe is a halo phenomenon, I believe it's an aneurysm because we have done a histological analysis. So aggressive vessel prep and paclitaxel is, in my opinion, a bad combinations. We don't know if we're going to see the same with other radiostenotic therapies.
And Theo, who do you treat this aneurysmatic degeneration? To leave it alone?
Clopidogrel, aspirin, nothing else. You're just looking. We have not seen any thrombosis on those aneurysmatic degenerations.
Yeah, I think at the moment it's really difficult to find a good definition because we know from the clinical studies that the halo phenomenon itself is not really related to bad clinical outcome. But of course, these special cases of aneurysmatic changes, and you can see that after various devices, they are related to bad clinical outcome. So this is actually this swimming supera stent in there, and I'm definitely sure it was not so undersized when it was implanted, but it was probably perfectly sized, and it's just swimming around in this distal SFA and just causing recurrent reocclusions because you will have some stasis there. So I think this is an issue. You can actually retrieve, especially these swimming supera stents, relatively easy by kind of getting access from outside to the stent, bringing in the wire here. Then snaring distally your wire via a 4 French catheter, having an 8 French sheath in place. And it's really amazing how kind of easy it is to pull out the supera stents. I mean, it can be difficult in case of really very intense restenosis, but not with a stent like that. And this is actually what you see then. You see this neo-intima attached. We did some supera stent extractions also in patients where they were actually undersized and when they were really difficult to retrieve. So I think this is the deepest vessel injury you can do as an, let's say, angiologist and not as a surgeon. The thing is they have an extreme high restenosis rate, and in this case we actually implanted then a wire band to kind of get rid of these ectatic changes, but it's really something you have to observe. It looks great after the intervention when you have retrieved the supera, but go back after 1 year and you will see an enormously fibrotic, very difficult to treat restenosis because it's just such an intense vessel injury. So this I'm just going to tackle very shortly. We have established a swine model of restenosis right now. We do some very fancy single cell analysis. I don't really understand it, but if anybody is interested in a collaboration, what's going on there is just amazing. You do sequencing now of single cells in your plaque. You don't address the full sequence of RNA you have in the plaque. You can really identify single cells and then get the full gene expression profile of these cells by really identifying very subtle changes. And we have submitted like a grant application to look at the impact of vessel injury actually on the restenotic process on such a single cell level in such a swine model. And so to end almost on time, how much atherectomy is enough? I don't know if I've answered this question. I think it depends and we don't always know. Thanks for the invitation.
Thank you so much, Sabine. I think it was great, guys. I'm amazed by your work, and I thank you so much because, I mean, we are plumbers. This is a plumber, let's say, congress, and this is like great. You know, it's a mix of plumber, very high-level plumber with retrieval of supera stent already deployed, and great science.